presentation. So for those of you who don't know me, my name is Marzi. I am a pharmacist at the Chronic Pain Clinic, and I just wanted to share some interesting facts regarding Suboxone therapy, an individualized approach. So I guess I'll just keep going on my timer. Hopefully it will not screw me up. There you go. So let's get started. So the objectives are understanding, of course, the rationale for microinduction. Why do we do that? This is a collaborative decision with the patient. It's not something that the provider only decide. What is precipitated withdrawal and Suboxone behavior at the new receptors? Of course, one size does not fit all, but what does that mean? Which I will be explaining. And there's some case regimens I will have for you, the ones that we use at the CPC, and some suggested literature for studying for those who are interested. Well, if it's an off-label approach, and they study people who really conducted the first study about Burns' method, they call it patient-oriented induction. That's my favorite term. When there are OUD concerns and there are harm reduction concerns, if there are concerns with the fact that the patient has to be in withdrawal, when they start just regular induction with Suboxone at cows of 12 and the cells of 17 might be really scary for some patients. That's when they use the microinduction. It does not have precipitated withdrawal. Yes, there will be some, but not as bad. And it could be used for patients on all kinds of opioids. So again, back to precipitated withdrawal, if there has been past failed induction, the patients have already experienced it. They have pain concerns, they have withdrawal concerns, so their compliance is going to be affected. So with the Burns method or microinduction, we make sure that those concerns will be addressed. So there are some goals of the treatment. What are they? Management is one of them, although Suboxone is not really indicated for pain. Well, it's not indicated for microinduction either. But it's still an opioid, and it could be used for pain relief through two mechanisms of action. One of them is the reversal of opioid-induced hyperalgesia. What is hyperalgesia? It's increased nociceptive sensitization that is caused by repeated exposure to opioids. And the next mechanism of action is improvement in opioid tolerance. So what is tolerance? It's basically needing more opioids for the same condition. 10 milligram morphine will not be effective. They have to keep increasing it for the same effects. The analgesia lasts about 4 to 8 hours, kind of short acting. It's suppressing opioid withdrawal, though, for 24 to 48 hours and sometimes even more. And it may be a schedule divided every 6 to 8 hours, and the maximum dose for pain relief would be 32 milligrams per day. The next indication could be for opioid use disorder management, which is kind of the most common usage of Suboxone. Usually 8 to 12% of chronic pain patients have OUD, but actually if you dig up the numbers, they may be even more than 12%. The doses could be split, so this manages the pain as well as OUD, as I described. After being stabilized on the daily doses, the maximum daily dose could be 24 milligrams per day. And it's, of course, again, the good thing about it is it could be dosed every 48 hours or even every 72 hours, which is helpful for people who don't have access to transportation or they just don't want to just take carries home, just one dose. So the Burns method, what you see is the method has been used. It's back in 2016, July 20th. The researchers published this study. As you see, it has been for one of the patients, specifically that was a lady using 3 grams of street heroin sniffed. And they have started that with the 0.2 milligram of buprenorphine on a once-a-day basis, and then it goes to twice a day. So Burns, based on that, what we use in Canada and United States, of course, as you see, 0.2 milligrams is a small dose. One of the small doses we can achieve is by a quarter of a tablet of a 2 milligram. You see half a milligram sublingual once a day, and then it can go as a twice-a-day basis incremental. it's always advisable to include an addiction specialist for that. The dosage of buprenorphine starts as a low and then it keeps going up. The idea is to discontinue the immediate release opioids at 4 milligram of Suboxone per day. And then as the extended release one, it could be stopped once at target dose of 12 milligram per day, but it could be also tapered off. But the immediate release, they don't taper, they just stop it at 4 milligram once daily. And as I mentioned, at 7 to 10 days, the target dose of 12 to 16 milligram will be achieved. However, what you saw there, this is actually the basis for providing better, more individualized regimens, I guess, based on the therapeutic response and adverse reactions. Because the patient will actually tell you, if as they tolerate, which way is best to go, what dose to use. So this graph shows why we really like buprenorphine, because it's kind of considered safe. It's a low risk of overdose due to ceiling effect. As you see, the smaller increments, as they are introduced into the system, they increase the percentage of occupied receptors. But once they reach 24 to 32 milligram per day, the occupancy gets leveled off. So it plateaus. So what do we do is we actually determine what is it? Is it for pain? Is it for opioid? Is it opioid use disorder, or is it for both? And many times you see that both are involved, both conditions. So the patient has to be well informed, understand Suboxone and what reduction is, what are the implications, the adverse effects. And it is easier to motivate the patient and make sure that they are actually hopeful for improved quality of life. So what is precipitated withdrawal? As it happens, because buprenorphine has a high affinity for opioid receptors, it's a sudden onset of withdrawal symptoms. So it kicks off the perfect fit opioid molecules and it pairs up with the receptors. Because it's a partial agonist, it can create the pain relief and partial withdrawal symptom management at first, but it doesn't have any euphoria. The naloxone component is, it doesn't play a role here. It doesn't contribute to withdrawal. However, the idea is to prevent it. I mean, we have medications, we send the patients home with prescription for withdrawal effects, but really, if we can prevent that, that would be the best. So precipitated withdrawal, what are they? It's nausea and cramps, it's vomiting, anxiety, insomnia, irritability, and muscle aches and joint pain. And it is at a very, very, very severe rate. And for management of these withdrawals, one of them is actually for induction. When you want to start the patient on Suboxone, they usually start at 2 to 4 milligram, and they have to have the patient already at the COWS score of 12 or the CELS score of 17. But really, for patients, this is not very good. Not everybody can handle this sort of thing. So immediately the microdosing comes to mind, and lots of providers are making use of that, especially at CBC. So here I start with a little bit of understanding as tolerance. As someone becomes tolerant to opioids, you see that they become less sensitive and they require more opioids to produce the same effect. And if there is an insufficient amount of opioid receptors occupied, the patient goes into a feeling of discomfort, which is called withdrawal. When there are opioids, however, in the system, they are a perfect fit of the receptor. So there's pain relief, there won't be any withdrawal symptoms. Euphoria also will be there, so everybody's happy. As the Suboxone or buprenorphine is introduced into the system, you see that it is actually capable of kicking off all those nice, beautifully fitting opioid molecules, and it sits on the receptor itself because it's really, really liking that. It's as I mentioned, it's a high affinity for those receptors. So what it does is, it's not a perfect fit. It creates that pain relief and a little bit of relief for the withdrawal symptoms, but there will not be any feeling of euphoria. So as the time goes, the buprenorphine dissociates from the receptor, but it keeps keeping the opioids from being attached to the receptors. So it just keeps exerting the effect at the new receptors. So This one it kind of explains it a little bit better, maybe a better visual. You see that when there is no buprenorphine, all the blue receptors are occupied by opioids, so 100% occupancy at 0.5 milligram of Suboxone or buprenorphine, you see 10% of the receptors, the orange colors. At 1 milligram, there are 30% occupancy. At 2 milligram, 40. At 4 milligram, nearly 60%. And at 12 and 16 milligram, the receptors are considered all occupied. But these numbers are perfect. And actually, this pharmacodynamics of buprenorphine is not exact like that. If you study further into it, you'll see the numbers are very different, but within the range. So examples, the case examples, they all indicate the fact that this is an individualized regimen, and one person may be working with one regimen, the other person may be getting into severe withdrawal. We just have to see what works best for who. Yes, there will be withdrawal. My apologies. This thing, it's as you see here, it says patient's report of precipitated withdrawal at 8 milligram per day, but actually it was severe withdrawal. It's not precipitated. Like, we have had patients at 8 milligram complaining and calling the clinic and saying, oh, I'm in withdrawal. So we manage them accordingly, but it's not precipitated withdrawal. So it's always essential to follow up with the patient on a daily basis to make sure that the dosages are actually working for them. And divided dosing, smaller increments always helps. Once the patient is stabilized, the 24 milligram per day will follow. So an example of what I call Regina method, and this is my first example because it's my favorite. Not that I've used it, but because it's Regina. The 0.25 milligram or 1/8 of a tablet has been as a started dose, and you see every 4 days interval on a once-a-day basis until 12 milligram per day. The next one, which is a kind of a variation of this regimen, as you see, I have exerted a 6 milligram divided, and it actually worked very well at the CPC. I have another example which incorporated a 3 milligram in divided doses. And then I did not jump to 8 milligram right away. You see the highlighted 4 milligram sublingual twice daily, and that was tolerated very well. Another variation is using a different technique. We will go by even a smaller increments on a every 3 days basis. Once at 8th day, we go by once-a-day dosing. And as you see, at 4 milligram, we stop all the, short-acting opioids. And at 12, all the opioids are stopped, including the extended release ones. So another one, which was quite I didn't hear from the provider, but this has been also a successful treatment, starting on an every 3 days basis, a 0.2 milligram sublingual on a daily basis, and then it goes to 28 days to 24 milligram at the end. But as you see, at the 12 milligram sublingual daily, we will provide the patient with PRN 2 milligram hourly of buprenorphine for a maximum of 16 milligram per day before we proceed to 24 milligram. So any of these examples that you have seen, these are all also a successful story, like a patient starting on microinduction, successfully coming off the opioids, and they're on their way for betterment. Also, here are some suggested readings for you if you want it. I recommend quite a good readings on those ones, better knowledge, a better understanding. And I'd like to draw your attention to my 7th reference, which is actually the original Burns method study, which took place in Switzerland, and that's why the method is called Burns method, July 20th of 2016. Well, thank you very much for listening to me. I think I'm at 52 seconds left, which still we will have more time in terms of the time that Jason has booked for me. If you have any questions, I'm ready.